5. Popular medications dangerous for the heart after 60. A man named Clarence sat in my office 2 years ago, 74 years old, retired electrician, the kind of man who showed up to every appointment on time, took every pill exactly as prescribed, and walked 2 miles before breakfast every morning of his life. He did not drink, he did not smoke, he did everything right, and yet, there he was. 2 cardiac events in 18 months. Exhausted in a way that sleep could not touch, muscle cramps pulling him out of bed at 3 in the morning, a sharpness in his thinking that had gone soft and blurred around the edges, like looking through a window that nobody had cleaned in years. 3 different doctors had told him the same thing. Clarence, you are 74. This is what getting older feels like.
I did not believe that. I have spent too many years watching what happens when people accept that sentence as an answer. So I asked Clarence to do something none of his other doctors had asked. I asked him to bring in every single medication he was taking, every pill, every supplement, every over-the-counter bottle from the medicine cabinet. He came back with a bag. I spread everything out on my desk, and within 5 minutes, I could see what had been happening to him for 2 full years. Not one problem, 3, running simultaneously, draining his heart of what it needed to function, and nobody had connected the pieces. We will come back to Clarence. How his story ends is the reason this video exists. But first, there is something you need to understand about what happens to your body after 60, because it changes everything about how medication works inside you. When a drug gets approved, it is tested primarily in younger adults, people in their 30s and 40s. One condition, one medication, a liver that processes everything efficiently, kidneys that filter at full speed. That is the body the drug was designed for. But that is not your body. Not anymore. After 60, your kidneys filter more slowly. Your liver metabolizes drugs at a reduced rate. Fat-to-muscle ratio shifts, which changes how drugs distribute and how long they stay active in your system. A dose that a 50-year-old handles without a second thought can push a 70-year-old into dangerous territory. And here is the part that genuinely concerns me. The average American over 65 takes 4 to 5 prescription medications every single day. Some take 8, some take 10. Each one was prescribed individually, tested individually, approved individually. But what happens when 3 or 4 of them combine inside a body that is already working harder than it used to? That question almost never gets answered in a standard appointment. There simply is not enough time. That is not your doctor's fault. It is a system problem. And it is a system problem that you can do something about, starting with information. So let me walk you through 5 medications that I have seen repeatedly, quietly working against the heart in people over 60. And for each one, I will tell you exactly what to ask your doctor at your next appointment. Not so you can stop anything on your own, so you can start a conversation that may never have happened without you bringing it up. The first one will not surprise you, but the details might. NSAIDs. Non-steroidal anti-inflammatory drugs. Ibuprofen, naproxen, diclofenac. They sit in nearly every medicine cabinet in America. You can buy them without a prescription. And because they have been around for decades, most people assume they are harmless. Especially for something as ordinary as a sore knee or an aching back. Here is what is actually happening inside your body when you take them regularly after 60. NSAIDs cause your body to retain sodium and water. That extra fluid raises your blood volume. More volume means more pressure against artery walls that are already less flexible than they were 20 years ago. A sub-study of the Precision trial measured this precisely. Ibuprofen raised 24-hour systolic blood pressure by nearly 4 points on average. And among the patients studied, new onset hypertension developed in over 23% of ibuprofen users. But it does not stop at blood pressure. NSAIDs also block an enzyme called CoX2, which produces a substance called prostacyclin. Prostacyclin is your blood vessel's natural protector. It keeps the walls flexible. It prevents dangerous clotting. block that protection, and you remove the safety net. The FDA strengthened its black box warning on all NSAIDs in 2015, not just for stomach bleeding, specifically for heart attack and stroke. The warning states that the risk can begin within the first weeks of use. A massive meta-analysis published in The Lancet, covering over 124,000 patients, found that diclofenac increased the risk of major coronary events by 70%. High-dose ibuprofen more than doubled it. Clarence was taking ibuprofen every single day for 2 years for joint pain. His doctor knew. Nobody flagged the cardiac risk. If you are using NSAIDs regularly, ask your doctor about topical alternatives. Diclofenac gel delivers the same anti-inflammatory effect locally with dramatically less systemic exposure. A pharmacokinetic study showed that topical application to a single joint produced roughly 94% less drug in the bloodstream compared to an oral dose. Same relief. A fraction of the cardiac risk. The second medication is one that saves lives. I want to be very clear about that. Statins have prevented more heart attacks than almost any drug class in modern medicine. I have prescribed them thousands of times, and I stand behind that decision. But there is a consequence that gets buried, and it involves something your heart cells depend on to produce energy. Statins work by blocking something called the mevalonate pathway. That pathway produces cholesterol, which is why statins lower it so effectively. But the same pathway also produces coenzyme Q10, a molecule that your mitochondria, the energy factories inside every cell, need to function. Your heart is the most energy-demanding organ in your body. It beats over 100,000 times a day without rest. It needs CoQ10 the way an engine needs oil. Without enough of it, the engine runs rough. Eventually, it starts to wear. A meta-analysis of placebo-controlled trials confirmed that statins significantly reduce circulating CoQ10 levels. Earlier research documented reductions of approximately 40%. In patients already dealing with age-related decline in CoQ10 production, that additional depletion can manifest as fatigue that does not respond to rest, muscle weakness, mental fog, and in some cases, measurable reduction in cardiac function. Clarence had been on a high-dose statin for 2 years. 2 years of his heart running below capacity. And here is what should frustrate you. CoQ10 testing is not standard practice. It is not in the guidelines. Some insurers will not even cover the test. The Q-Symbio trial, a randomized double-blind study of 420 heart failure patients, found that those who supplemented with CoQ10 at 300 milligrams daily had a 50% reduction in major cardiovascular events over 2 years. Cardiovascular mortality dropped from 16% to 9%. Those are not small numbers. The fix is straightforward. 100 to 200 milligrams of CoQ10 daily, taken alongside your statin. It is over the counter. It is well tolerated. And the question you bring to your next appointment is simple. Should I be supplementing CoQ10 alongside my statin? Write that down. Not, should I stop? Just that. The third medication is one most people do not think of as a heart drug, and that is precisely what makes it dangerous. Proton pump inhibitors. Omeprazole, pantoprazole, lansoprazole. Roughly 15% of the American adult population takes them. Many have been taking them for years, some for decades. They were designed for short-term use, 8 weeks, 12 at most. But the refills kept coming, and nobody scheduled the conversation about stopping. Here is what happens when you suppress stomach acid long-term. You lose the ability to absorb vitamin B12 efficiently. Your stomach acid is not the enemy. It is a gatekeeper. You need it to extract B12 from food. Block that acid year after year, and B12 levels quietly decline. A large study published in JAMA in 2013 examined over 25,000 cases of B12 deficiency. Those who had used PPIs for 2 or more years had a 65% increased risk of deficiency. Higher doses push that risk even further, to 95%. Why does a heart concern itself with B12? Because B12 is essential for metabolizing an amino acid called homocysteine. When B12 drops, homocysteine rises, and elevated homocysteine directly damages arterial walls. It is an independent cardiovascular risk factor that gets almost completely ignored in standard workups. But PPIs do not stop at B12. They also deplete magnesium. A meta-analysis of over 130,000 patients found PPI users were 71% more likely to develop low magnesium levels. Magnesium regulates the electrical signals that keep your heartbeat steady. Deficiency is directly linked to arrhythmia, to irregular rhythms that can become dangerous, to cramps at 3 in the morning that wake you up and leave you wondering what is happening to your body. The FDA issued a specific safety communication in 2011, warning that long-term PPI use can cause low magnesium with cardiac consequences, including atrial fibrillation. Clarence's B12 came back critically low. His magnesium sat at the very bottom of the normal range, technically within limits, so nobody acted on it, for 2 years. If you have been on a PPI for more than 12 months, ask for B12 and magnesium levels at your next blood draw. For B12, methylcobalamin taken under the tongue bypasses the absorption problem entirely. No stomach acid required. For magnesium, the chelated form, magnesium glycinate, is far better absorbed than the cheap magnesium oxide you find in most drugstore bottles. 400 milligrams daily. And ask whether there is a plan to taper off the PPI. Do not stop abruptly. There is a rebound effect where acid surges back worse than before, which drives people right back onto the medication. A gradual, supervised taper is the only safe way. 3 medications down, each one quietly removing something your heart needs. CoQ10 from the statin, vascular protection from the NSAID, B12 and magnesium from the PPI. All 3 were running simultaneously in Clarence for 2 years. Each specialist saw their piece. Nobody asked what the combination was doing over time. 2 more to go, and these last 2 are the ones that changed how I think about prescribing permanently. The 4th medication involves something I have seen with my own eyes during surgery, and once you understand it, you will never look at it the same way again. Warfarin. It has been around since the 1950s. It is still one of the most commonly prescribed blood thinners for patients over 65. Atrial fibrillation, deep vein thrombosis, mechanical heart valves. Warfarin is standard care for millions of people. It prevents dangerous clots. It prevents strokes. I am not disputing that. But warfarin works by blocking vitamin K, and there are 2 forms of vitamin K, and warfarin cannot tell them apart. K1 is involved in blood clotting. That is the one warfarin is supposed to block. K2 does something entirely different. K2 activates a protein called matrix GLA protein, whose entire job is to grab calcium and send it to your bones, away from your arteries. Without K2 activity, calcium has nowhere to go. It drifts. It settles into blood vessel walls. Your arteries become rigid, calcified, like old pipes slowly filling with mineral deposits. Warfarin blocks K2 right along with K1. So while it is preventing clots, it is simultaneously removing your body's primary defense against arterial calcification. A study published in JCC Cardiovascular Imaging analyzed data from over 4,000 patients using serial imaging of their coronary arteries. Warfarin use was independently associated with progressive coronary artery calcification, even after adjusting for other factors. A separate randomized trial compared warfarin directly against apixaban for 52 weeks. The warfarin group showed significantly greater progression of calcified plaque. As a surgeon, I have seen what heavily calcified arteries look like. They do not bend. They do not give. They make every procedure harder, every recovery longer, every outcome less certain. Does this mean warfarin patients should stop? Absolutely not. Untreated atrial fibrillation carries roughly a 5% annual stroke risk. That is not something to gamble with. But it does mean asking 2 questions at your next appointment. First, given that newer anticoagulants exist, is warfarin still the best choice for me? Medications like apixaban and rivaroxaban do not interfere with K2 in the same way. Second, has anyone measured my coronary artery calcium score? It is a simple, low-radiation CT scan. It takes minutes. It tells you exactly what is happening inside your arteries right now. It is one of the most underused cardiac risk tools in existence. The 5th medication is the hardest one for me to talk about. Not because the science is complicated, because I recommended it myself for years to patients who trusted me, and I was wrong. Calcium supplements. If you are a woman over 60, there is a very good chance at least one doctor has told you to take calcium for your bones. 1,200 milligrams a day. Take it with food. It barely registers as a medical decision. It feels like common sense. In 2010, the British Medical Journal published a meta-analysis that changed my practice permanently. 15 randomized controlled trials, nearly 13,000 patients. Calcium supplementation without adequate vitamin K2 and D3 was associated with an approximately 27 to 31% increase in the risk of myocardial infarction. Let me say that again slowly. Roughly 1 in 4 to 1 in 3 women taking calcium supplements faithfully every morning may have been meaningfully increasing their cardiac risk while believing they were doing something healthy. The mechanism is what cardiologists now call the calcium paradox. Supplemental calcium enters the bloodstream as a sudden concentrated surge. Your body does not know where to put it all at once. Without sufficient vitamin K2 to activate the proteins that direct calcium to bone, some of it ends up in arterial walls. The same calcification process we just discussed with warfarin, but this time driven by the supplement itself. The Rotterdam study, one of the longest-running cardiovascular studies in Europe, followed nearly 5,000 people and found that those with the highest vitamin K2 intake had a 57% lower risk of dying from coronary heart disease and a 52% reduction in severe aortic calcification. Vitamin K1 showed no such benefit. K2 specifically. If you are taking calcium supplements, do not stop abruptly, especially if you have documented bone density loss. But bring this question to your doctor. Should I be taking K2 and D3 alongside my calcium? For most patients, the answer is yes. K2 as MK7, 100 micrograms daily. D3, a minimum of 2,000 IU. And wherever possible, get your calcium from food first. Dairy, leafy greens, sardines with the bones. Supplements to fill gaps, not as the primary source. Let me come back to Clarence. After reviewing his complete medication list, I sat with him for 40 minutes. Not 7, 40. Every drug, every dose, every interaction. Then I called his cardiologist and his GP, and we built a plan together. CoQ10 at 200 milligrams daily. His B12, critically low, was addressed with sublingual methylcobalamin immediately. Chelated magnesium was added. Daily ibuprofen was switched to topical diclofenac gel. Same anti-inflammatory effect, a fraction of the systemic exposure. His GP began a gradual PPI taper. K2 and D3 were added alongside his existing calcium. Nothing dramatic, no new surgery, no breakthrough medication. We simply stopped depleting the things his heart needed to function and replaced them. That is all. 6 months later, Clarence called. He said, "I feel like myself again." The exhaustion was gone. The 3 a.m. cramps stopped within the first month. Cardiac follow-up showed measurable improvement. His GP was genuinely puzzled. The improvement did not fit the expected trajectory for a 74-year-old man. Nothing changed, except the full picture being addressed for the first time. That is what stays with me after all these years. Not the complexity of what went wrong, the simplicity of what helped. A few targeted supplements, a medication swap, A 40-minute conversation that 3 previous appointments had never made room for. The medications on this list are not villains. The doctors who prescribe them are not careless. The problem is a system that rewards the prescription and has no mechanism to reward the follow-up question. No time built into the appointment for, what is this combination quietly doing to you over the next 2 years? You cannot fix the system today, but you can do one thing before your next appointment that could change everything. Write down every medication you take, every prescription, every supplement, every over-the-counter pill. Put them on a single piece of paper. And at the top, write 3 words. What am I losing? Every drug has a trade-off. You deserve to know yours. Statins lower cholesterol and deplete CoQ10. NSAIDs reduce pain and remove vascular protection. PPIs suppress acid and block B12 and magnesium. Warfarin prevents clots and accelerates arterial calcification. Calcium supplements protect bones, and without K2, harden arteries. None of these trade-offs mean the medication is wrong for you. They mean the conversation is incomplete without them. And you deserve the complete conversation. Everything in this video is general educational information based on current medical research. It is not a substitute for your personal medical care. Please do not stop or change any prescribed medication without speaking to your physician first. Bring this information to your next appointment. Have the conversation. Your doctor is your partner. And these strategies work best when they work alongside proper medical supervision. Take care of your heart. It has been beating for you every second of your life, without ever asking for anything in return. The least we can do is pay attention to what we are putting into the body that surrounds it.